Good afternoon. I heard good lunch conversations happening, which I'm happy to hear. Welcome to the UC Student and Policy Center. My name is Catherine Baker, and I'm director of the center. And there's a brief interactive moment to this program. Raise your hand if this is your first time at the UC Student and Policy Center. Excellent. Welcome. The newbies, the freshmen, we are very happy to have you here. I'm going to say a little bit about what happens here at the UC Student and Policy Center, and of course, hope this is one of many times you will be here for a great program you're going to learn a lot from. This center is part of the University of California's presence in our policymaking community. As you may or may not know, the University of California is the third largest employer in the state of California behind the state and federal government. We have a presence in every single, not just our 10 campuses, including UCSF, but in every single county, legislative, assembly, Senate, congressional district. We are everywhere in the state. And part of the university's mission, in addition to excellent teaching and a cutting edge innovative research, is public service, to be of service and have the work that they do get into the hands of Californians and policymakers to help them solve problems and understand them better so there are better solutions. And this center is a very real in-person way in which we do that through conversations like today that's been brought to you by CSAC. Thank you to our county association friends and the Goldman School of Public Policy. So today is a very real manifestation of that. We have other programs that go on throughout the year where you can come and learn good information and find solutions. And that's what the University of California is all about. It's research, it's teaching, and it's public service mission. So my last question for you before I turn it over to our terrific Dean Wilson is raise your hand if you went to a University of California campus, anywhere for years. Excellent. If someone in your family went, if a total stranger that you've never met before has probably gone to the University of California, that's part of the university's mission and impact on California, and we are honored to get to do it. I also am going to just tease out some information, some news and information about the Goldman School of Public Policy and the UC Student and Policy Center that you will hear more about, I hope, throughout the day. And that is a master's in public affairs that will be possible in 1 year program here starting at the center. That's all I'm going to say. But if you work and live in this area within just a few blocks and you are involved in government and public affairs and really want to step up your career and credentials, you're going to want to hear from us on this program in the Goldman School. So that's your teaser. And with that, I'd love to turn it over to Dean Wilson from the Goldman School of Public Policy to take it away from here. Please welcome Dean Wilson.
Thank you for the introduction. Catherine has been a great partner. I am David Wilson, Dean of the Goldman School of Public Policy. I've been in this role for about 4 years now. This is my 5th year. And since I arrived at the Goldman School, I've been very much focused on ensuring that Goldman, which is in Berkeley, California, gets off the hill that we're located on and in the places where we could be more of a resource and a partner. As we know, higher education is going through a lot of turbulence right now, and we need to showcase our value add and be more of a resource for those who need the talent, tools, values, and methods that we use. And so locating here in Sacramento is key to this broader agenda of being more of a partner and more of a resource. So I'm really excited about the opportunity that we've been able to engage with CSAC, and we're doing this through this model of agile government. We're a school of public policy. Schools of public policy and government and public affairs and the like are the only academic units that are expressly created to improve the work of government, to ensure that governing is more effective and more efficient. We have the science, the models, the expertise, the wisdom, the networks, and the like. And so what we want to do is take that knowledge and bring it to a place that really helps us understand issues better, but we can also do more to help them. So our Agile Government program will be cornerstoned around the Masters of Public Affairs. It's a 1-year mid-career program, starts in May, graduates in May. It's based around projects and accelerated learning opportunities. And so we want our students to have real world expertise and real world experiences. And the work that Shannon Arvizu and our other team are doing around Agile are helping us to build that model of change making for government. We want to make sure that we're moving towards greater trust through our different tools like Agile Government and public policy analysis and processing. So I am really excited to be here. I'm really excited for the partnership. I'm really excited to see the turnout here to think about the work we can do together now and in the future. So with that, I'm going to turn it over to Jeff Griffith. Jeff, pleasure to come forward. Supervisor and President of CSAC. Wonderful.
Thank you, Dean. So I'm Jeff Griffiths. I'm an Inyo County supervisor. For those of you who don't know where Inyo County is, it's a county of about 19,000 people, 10,000 square miles over on the other side of the mountains, where Death Valley, Mount Whitney. But I'm also currently the president of the California State Association of Counties, or CSAC. And for those of you who don't know, CSAC is the advocate for county government in Sacramento, in Washington, D.C. But more importantly than that is it creates partnerships and provides best practices for ways that counties can better provide services for our residences. California is one of the very few states that delegates Medicare services administration to counties. And there are currently, nearly 15 million of our 40 million residents on Medi-Cal. And of the 58 counties, they're wildly different. We have Alpine County with about 1,000 residents and LA County with 10 million residents. We have rural counties, urban counties, counties that are well-resourced, and counties that are struggling. And layer on top of all of this, the reductions and the uncertainty that's coming from the federal government. And so I'm really excited about this partnership that we're having with the Goldman School. It's something that CSAC has never quite done before. And we have a freight train or a cliff or whatever you want to call it coming at us in how we provide these services for our residents. And this process is a way that we can do this thoughtfully and serve our constituents the best. So I am going to turn this over to the director, Dr. Shannon Arvizu.
Thank you all. And I am going to be sharing with you a presentation of our findings from our Medi-Cal Policy Snapshot project. So a little bit of an introduction to me. I'm at the Agile Government Initiative at the UC Berkeley Goldman Policy School. I was a former senior advisor to the White House Chief Data Scientist and to the Chief Data Officer at the Commerce Department. And I want to introduce our established research team. I'm going to invite each of them to share their name and a little bit about why they were interested in this project. And so I'll pass it on over first to Emma.
Hi, I'm Emma. I'm a second year Master Public Policy student. And I wanted to get involved in this project because I think it's really important to help develop these kind of data products, these products for counties to understand rapid policy shifts in a way that is so because everything is happening so fast.
Thank you. Hi, everyone. My name is Godwin, and I'm a second year Master of Public Policy student. I got interested in the local economic development and the policy dynamics in there. So when I got access to apply for this project, I was particularly happy. And it has revealed to me so much and have learned so much in this process. And I think this is the best best experience anyone in local economic development can have. Very appreciative of that.
Hi, everyone. My name is Sanaz, also a second year MPP student. I joined this because I think this is a really important time for health and social policy, and I wanted to learn how to apply agile, responsive policy tools in real time.
So with that, so here's some of the things I want to share today. One, I want to give a little bit of an origin and overview of our Counties Rise project. And then we're going to go into a deeper look in what the snapshots themselves say. And then I want to share a little bit about the insights from county interviews. We interviewed over 20 plus counties to understand what are their experiences so far with current and proposed changes to Medi-Cal. So a little bit about the origin story of this project. So you heard this term Agile Government Initiative. This is a new effort at the Goldman Policy School. And we think about this effort as equipping present and future policymakers and civil servants with the abilities to deliver the right things in the right way and at the right speed for the communities they serve, especially in times of disruption and change. And when I joined this initiative a few months ago, I thought, it would be great to develop some case studies that we can then start to teach students about how state, local government responded during the pandemic. And then when we started to do that work, we thought, well, wait a second, we're actually in another stage of disruption and change. So rather than teach agile policymaking, what could we do to inform agile policymaking? And to provide a little bit of a distinction between traditional policy research and agile policy research, we think about the distinction here, whereas traditional policy research is more in-depth, comprehensive analysis of past policy decisions, or maybe informing future decisions, whereas here we're more focused on rapid iterative analysis to inform near-term decision-making. We were working in shorter-term, quick cycles. This was a 12-week project. We're focusing on more flexible and adaptive methods of research, and the emphasis is more on near real-time data and feedback with continuous embedded stakeholder engagement. So the way that we develop these snapshots is hand in hand with each county with multiple touch points, with the output being more working drafts or toolkits or dashboards, not so much formal reports and policy papers, with the need to be highly responsive to change. Multiple iterations of the snapshots were produced during this time, and also recognizing that there is a level of risk that comes from producing agile policy research and being clear about learning from those failures. So with that, we scoped out the county's RISE for Medi-Cal. RISE is an acronym, stands for Research, Initiative, and Service Essentials. And we had two goals: to prototype these sense-making data products in collaboration with counties, and then to surface emerging insights from counties themselves to understand what were some pre-existing challenges, what was already working very well at the county level, and what are some of their emerging concerns. Also, what this pilot is not. It's not intended to replace or supplant advocacy efforts. There is a robust network of organizations in this space that do that very well. Also, not intended to be a definitive and authoritative source on Medi-Cal policy research. We conducted no original research for these snapshots. We drew from existing stats and data sources, a lot of them produced at the state level, but we were able to parse that data and then be able to contextualize it within the county situation so that way counties can more easily make sense of that data. So a little bit more about what these snapshots are about: custom data products produced with the counties. We intentionally designed them to be educational. This is a very complicated policy space. And so what we wanted to do is to present what the program is about in plain language. We also know this is a very politicized policy space, as much as possible using nonpartisan language. We want it to be easily understandable to non-experts in the Medi-Cal space. What's in the snapshots? I'm going to go a little bit deeper, but at a high level, we have a page related to the current state of Medi-Cal in terms of how it's administered, a profile of enrollees. We have a page around the policy changes, both at the federal and the state level. We talk about projected population impacts, projected health system impacts, and projected economic impacts. How the snapshots were produced, as I mentioned, we did this over a 12-week period. First 6 weeks were around just gathering all the relevant data and research about the policy changes, synthesize them into an easy to understand policy story, and then format using a data product platform called My Sidewalk. And then we would prototype early versions, share them with a small set of counties for feedback, and then we continued to prototype subsequent versions and share with an even larger set of counties for feedback and production. Here was our county snapshot workflow. So the counties had to request a snapshot. So CSAC let their community know that we had this pro bono technical assistance service available to them. They would request a snapshot. We would produce a first draft. We would meet with them to get feedback. And then we did multiple rounds before the county approves and the snapshot goes live. We were able to produce our final version on Friday. So now that is out for final approval. What we heard so far about how counties plan on using the snapshots: majority of counties that we spoke with describe the snapshots as a practical tool for communication, planning, and advocacy. They appreciate that it's tailored to their local context. They plan on using it to educate their decision makers, to support their advocacy work, and even to inform staff across departments, especially line staff who maybe don't always see the big picture of their work and their impact. We also heard that some counties plan to use this for public communication, for media engagement. They got a lot of media requests to help explain and break down things, and now they feel like this is a really good source that they can direct them to. And then we also heard that the snapshots were going to be used to inform some county workshops that were already planned. We heard, wow, this is so great. I have this workshop planned in 2 weeks. I can use this with that. So, and the other is we were very intentional about capturing this information in infographics. We were told many times, can you help create a visual story with this? And so we were told folks would like to share those infographics as well. So in addition, we interviewed over 20 county leaders, and you can see here the roles of county officials we spoke with, including health service directors, human service directors, even a few hospital CEOs and CFOs. And we also got a good lay of the land of the Medi-Cal policy field. And so there are several key agencies and associations that support counties in Medi-Cal data analysis, policy analysis, implementation, communication, advocacy. You can see those organizations listed here. Some of those organizations are also in the room today, so thank you very much. I want to share some key challenges of this work that we learned along the way. As I mentioned, there are, with this type of work, expected challenges. This is a shifting landscape. When we started the work, HR 1 had not passed. Also, California state budget had not passed. Halfway through, both of those policies, those policy milestones had passed. And so there's a lot of not only iterations in what we said, but also we recognize that this is a shifting narrative landscape, that there were ways in which this information was framed before those bills passed that then shifted after. And it was really important for us to be attuned to those changes. This is also, as we know, a very complicated policy domain. In 2025, we counted over 18 federal and state substantive policy changes that impact Medi-Cal enrollment or funded services. And then we also note there's, even before 2025, just the way that the program is designed, there is this dynamic tension between the role that the federal government plays, the state government plays, and county governments play. And so being aware of that tension and attuning to it was really important. Other key considerations, county level differences. As Supervisor Griffith had mentioned, there are many different contexts for how Medi-Cal is administered within each county. And then because we wanted to do these rapid iteration cycles, we knew that there were a lot of benefits of seeking feedback early from the counties on what was in the snapshot, but that also meant risking what it might mean to share unfinished products. And so that was also a tension we were navigating. A few other key considerations. We know that county HHS folks have a strong need to manage local level and state level stakeholder communication. And it was really important for these snapshots to be seen in service of their needs. We also know in this organizational field that there is a key need to know who's doing research in this space, what their intentions are, and what role that they might play in shaping how those policy changes are understood. And then lastly, data sensitivities. These snapshots are using, in many cases, projected data or data that will tell us directionally what may happen. And there are a lot of sensitivities to how projected impact data may be understood or lead to unwanted impacts. So those are some of the considerations we learned along the way. Let's go inside the snapshots. I'll share with you what we actually were able to unearth for counties. So as I mentioned, part of the snapshots is a Medi-Cal 101 for a non-technical audience. And one of the key through lines through the snapshots is the narrative that this is more than just health insurance program for specific populations, that the way the program is designed is that it supports the funding of local health systems and directly and indirectly supports local economies. So we would produce, this is an example of one of our infographics, how Medi-Cal benefits local economies, just kind of up front and center. This is not a common narrative that you hear associated with this policy, but it's something that we heard loud and clear from our county level stakeholders. Another key through line is counties have played a key role in improving access to healthcare coverage. We know now in the state of California, close to 95% of Californians are now covered, and that is directly because of the work that county governments have been able to put in place. And so in the snapshots, we have timelines by county, how Medi-Cal enrollees have increased from ACA to present day with key milestones. And then we also have some geospatial maps where we are able to look at Medi-Cal enrollees per zip code by capita. And as you may surmise, we are able to demonstrate that counties with lower socioeconomic indicators tend to also be places with higher Medi-Cal enrollment. And then we also did our best to make sense of these 18 plus substantive federal policy changes. And so we have a page where we go through and provide a high level detail with links to go further in depth if you'd like to know more. We also created a timeline of the federal and state policy changes that are intended or that will be happening over the next 3 years. We have a page in the snapshots that talks about the local hospitals, clinics, and providers that may be impacted. Again, pulling from state data and parsing it in a way that helps folks make sense of the local context. And there's another example of an infographic that we have in our snapshots where you can start to see the connections between how fewer people enrolled or able to access Medi-Cal leads to more people skipping preventative care, chronic conditions go unmanaged, leads to higher ER visits, also increased compensated care, pressure on the local health system. And then you can also see how the hospital and clinics and providers are also impacted by less funding and reduced hours and services. Again, this is stuff people in the Medi-Cal policy space know this. You're probably looking at this and you're like, yeah, duh. But this is drawing these connections for the public and other county level stakeholders who are not in this space are able to see this and are able to more quickly make sense of what's happening. And then lastly, we have a page in the snapshots that's about local economies impacted. And for this page, we draw heavily from the UC Berkeley Labor Center's study on projected job loss. And we have the UC Berkeley Labor Center on our panel in just a few moments to talk more about that. So lastly, I wanted to share some insights from our county interviews. We asked them 4 questions. Before the changes, what was working well with Medi-Cal administration? Just to change the tenor of the conversation. And so we have some of those strengths to share with you. And then we also asked about some pre-existing challenges, emerging concerns, but then also feedback loops. What is your channel of communication now for sharing your experiences to inform present and future decision-making? So in terms of what's been working well, here's what we heard. 1, county has been working really hard to significantly reduce the uninsured population. And they've been able to do that in partnership with a lot of community-based organizations by co-locating eligibility staff in community spaces, by proactively outreaching the community during those enrollment periods. And we heard the role of trusted partnerships for outreach and enrollment several times. So we wanted to just emphasize that here. We have this quote from a county that says, "Our partnerships with community-based organizations are the only reason we can reach certain populations. Some people will never come to a government office, but they'll talk to a trusted local group." Another thing that's been working well, operational efficiencies for eligibility work. So many county governments we talked to have mentioned the work that they're doing to have a no wrong door approach, make it as easy as possible for people to apply for multiple programs through a single point of contact, cross-training their staff across multiple programs, Medi-Cal, CalFresh, and this way they can shift the workload dynamically, prevent service bottlenecks. We also heard a lot about call center optimization. Eligibility staff are under a lot of stress, and to be a part of eligibility staff, you have to have a significant amount of knowledge to be able to do that role well. So counties have been doing a lot to make sure that they can adjust call center times to help the eligibility staff have dedicated time to process cases and then other time to do intake. cross-agency coordination. During the pandemic, there was a lot of work that was put in place to help multiple agencies in a county, whether it's public health, social services, behavioral health, start to coordinate. And a lot of those existing networks continue to be in place because they found so much value from that. We also heard that counties have been able to innovate on their service delivery, especially for populations with complex health needs, whether that's putting in place street medicine teams or community paramedicine. And then we asked what challenges existed before these state policy changes. And we heard two things. One, there continues to be limited access to care in some counties, particularly rural ones, across primary, specialty, behavioral health care. We know that there are lower reimbursement rates, which then also potentially limits Medi-Cal patients that are able to, well, I just have this quote here, I'll just read. With per beneficiary rates so low, providers have to limit how many Medi-Cal patients they can see for preventative care, which means more people end up in the ER. And then long distances to reach care, especially for some folks in remote areas. We also heard that whereas some counties have been able to do a lot to support their eligibility workers, some other counties still are struggling with turnover amongst their eligibility staff and also language barriers, particularly in communities with large immigrant or indigenous populations. So then we get to emerging concerns. Obviously, budget pressures is top of mind for everyone. Thinking about what to do in face of reductions in compensated care and potential loss of MCO tax revenue, need to maintain staffing levels with flat or declining budgets. Some counties are exploring revenue stream pathways. Others warned against regionally variable revenue streams that could put some counties at a disadvantage. We had a county share this quote. It's kind of political. The feds say they reduced taxes with HR1, but all they did was pass the cost on to us. Some counties expressed that sentiment. There are concerns about work requirement implementation, uncertainty in how to comply, what activities will count, how monitoring will occur, how counties will track compliance. They're concerned that maybe Medi-Cal requirements might disqualify many working individuals who, for a variety of reasons, may not be able to meet the hourly threshold. And then procedural hurdles, even for those who are eligible, that could create disenrollment. There's concerns about increase in ER usage. We've heard this a few times in the presentation already. There's also, we heard from some counties, requests for disenrollment out of fears or fears of enrollment. So there's already some confusion, especially among immigrant families, about continued eligibility. Some counties have mentioned they've seen a decline in appointment attendance. And then a few counties are already being proactive about preparing guides like one-page handouts with clear information about what to expect. And then there are some counties that are already starting to anticipate coverage losses and see what they can do. So looking at existing data to proactively identify who are going to be the folks that are required to meet work requirements, how they could start plan ahead for that. One county talked about the coverage cliff. So this is when individuals lose Medi-Cal eligibility but cannot afford covered California premiums, leaving them uninsured. And then also concerns about not having enough staff to meet the eligibility requirement compliance. And then some are already proactively adjusting or hiring ahead of anticipated attrition. There are also some behavioral health concerns. As we know, counties administer many different types of behavioral health services. And so there's concern that if some populations lose access to ongoing care, it might lead to mental health deterioration, more frequent high-cost interventions. There's also some concern and ambiguity around Proposition 1 funding shifts that was passed last year to improve access to behavioral health services. And there's concerns about how much funding will return to local behavioral health services and how it will be allocated. And then lastly, just related ripple effects. So there's concern that impacted hospitals, clinics, providers may have to seek additional revenue from private insurers. So potentially seeing rate increases for privately insured folks, and then strained federal qualified health centers and indigent care programs. So it could pour more uninsured patients into those programs that are already strained. So lastly, we asked, what feedback loops do you have between state and county stakeholders? And we heard overwhelmingly the role of state agencies, intermediary groups like CSAC, like CHIAC, like many of the other organizations listed here. They rely on them for timely updates and advocacy support. And they report that there is regular communication with DHCS and the California Department of Social Services, but they noted a lack of concrete implementation guidance from the state, and they're preparing for future rounds of advocacy, and some are working directly with their own state and federal lobbyists. We want to conclude with this quote from a rural county. It says, in rural areas, it's not compete, it's cooperate. Everyone knows we won't get together, we won't get through this without working together. So with that, I will conclude this part of the presentation. If you have questions, you can find me during the break, and I'm going to pass it on over to Angela Hart, who's going to lead us in the panel discussion.
Hi, everyone. What day is today? Tuesday? Hi.
Hi.
I'm Angela.
Hi, I'm Jeff.
Nice to meet you. Nice to meet you, Jeff.
Nice to meet you.
Hi, everyone. Thank you for your time and attention. My name is Angela Hart. I'm a health reporter for KFF Health News. I'm based here in California. We have health reporters all over the country, so it's been really quite a time to be a health journalist right now, and really trying to understand the implications with not only this this newish president, the Trump administration, but also all the changes happening in California and how they're really going to impact patients. So I'm looking forward to this panel today to broaden the discussion of a lot of the important points that are just made. I just want to say one thing I really learned, I've learned being in Sacramento for all these years as a reporter, is the very vital and important role that counties play in health and human services, and also in homelessness, which is of course a healthcare issue. So I think that I just think that that can't go unnoticed, and I think counties are at the forefront of this. I'm going to refer to my notes down here, so if you guys see me looking down, just so you know. So to that end, I just want to start out with a broad kind of big picture question for everyone, and then I'll do a little kind of round robin. So to that point, counties are at the forefront of implementing major health policy changes that have happened under Governor Newsom in recent years, major expansions in benefits, even into the social services realm, major services and major expansions in behavioral health care, changing of funding mechanisms, and of course, expansions in the number of people who are covered. A lot of this stuff is being shaken up in real time with HR1. And even outside of the federal legislation, there's a lot of changes going on. And I just wonder open-endedly, what challenges do you see that you're maybe most concerned about, or that could have the biggest sort of ripple effects on California, on counties, and think most importantly on patients? I'd like to start with you.
Thanks. I would start off with something positive, and that is because of the waivers and the expansions in CalAIM and all of the things that have happened over the last several years, we've been able to provide wraparound services for our most vulnerable and our most expensive, clients, and that's been something that's been a success story. And both with HR1 and also somewhat the changes that were made with Prop 1. All of that is at risk. And the biggest danger that I see is systemic failure, particularly in rural hospitals. We're hanging on by a thread to begin with. And there's sort of a minimum level of service that you need in order to maintain a rural healthcare system. And if you lop off a huge percentage of that, the whole system may fail. So I fear that we're going to lose all of the gains that we made in holistic wraparound care, but then also like our entire system is at risk of crumbling.
Wow. Michelle?
Thank you, Angela. Michelle Cabrera with the County Behavioral Health Directors Association, representing county behavioral health agencies throughout California. Obviously, the biggest impact that we see is coming from HR1, which is a big, beautiful something, and it, will have an impact on enrollment as well as eligibility through work requirements. This, there are a number of exemptions built into HR1 for individuals with behavioral health conditions under different premises, right? One is if you are engaged in substance use disorder treatment. Another is if you qualify as medically frail. All of this still needs to be interpreted through secondary guidance at the federal level. And so it's a big TBD on how that will be interpreted. And one of the concerning things, I think, from my perspective is behavioral health conditions are the world's leading cause of disability, meaning it has a significant impact on your ability to go to school or work if you develop a serious mental illness or a substance use disorder. And so tying into work requirements, we really do need maximum flexibility to ensure that people who are in the safety net, who've managed to get to our doors in county behavioral health, then are able to access the services and treatments that they're entitled to. And one of our big concerns is, we've had, prior to Governor Newsom, quite a bit of austerity in the space of health and human services. And so this period that we've lived through over the last 5-6 years has really been about addressing that pent-up demand in healthcare and human services. And so it can feel at the systems level incredibly overwhelming to manage so much change all at once, but it really does reflect that. And, the premise for us moving forward was that, we were going to be able to use Medi-Cal in new ways, that we were going to be able to maximize existing revenues, especially county behavioral health revenues, in ways that helped us to bring in a larger degree of federal spending. All of the sort of underpinning of that thesis is now at risk. And so in terms of real lives, counties will still continue to try and meet the needs in the community. But as the supervisor said, I do think that there is the possibility of an unintended consequence of destabilizing the sort of overall economy as people can't access healthcare, can't get better, and ultimately that then loops back around and has a negative impact on the safety net itself by increasing demand when our ability to bring in money is then significantly compromised.
Miranda, can you go a little bit deeper into what Michelle just touched on with the broad economic impacts of HR1?
Yeah, absolutely. Hi, Miranda Dietz. I'm the interim healthcare program director at the Labor Center at UC Berkeley. So yeah, we did a study looking at if California lost $20 billion, say, in federal funding per year, which is, close to what the governor is saying we will lose as a result of HR1. And that'll result in more than 200,000 lost jobs in the state of California. And that's, a significant increase in unemployment. That'd be 0.5 percentage point to a percentage point drop or increase in unemployment. And that's not just healthcare jobs, right? That's the biggest impact is healthcare jobs, so those rural hospitals and other places that are struggling with funding. But then it's also the supporting jobs, the laundry, the cafeteria, the places where folks go on their lunch break. And then just the jobs in the rest of the community, right? You lose your job and you're spending less at the grocery store. So there's really ripple effects across the whole state of California from these cuts.
Brian, I want to drill down on something with you in the next round, but I would be interested, I mean, universities play such a vital role in the healthcare delivery landscape. I wonder if you could drill down on that a little bit and the impacts of the federal legislation and other changes you might see coming from this administration.
Ryan Miller, Director of Health Policy and Regulatory Affairs for UC Health. And thank you to CSAC and thank you, Angela, for moderating the panel. At UC Health, we operate 6 academic health centers. We also have 21 health professional schools. So I think we're offering kind of a provider, but also like a medical education kind of perspective. Yeah, I think I would lift up what Supervisor Griffiths was expressing in terms of concerns to rural hospitals, to providers in general. The bill, the impacts on provider taxes and state directed payments, really fundamental and crucial financing mechanisms for providers in the state are really very severe. The Hospital Association estimates over 10 years a loss of revenue between 66 and 128 billion dollars. The Public Hospital Association is estimating revenue losses of up to $7 billion. And I mean, those are pretty unimaginable figures, I would say. So I think when you're thinking about the provider community in general in California, there's a really serious problem there.
Just so everyone, you guys might be aware, but just to explain a little bit what Ryan was talking about the provider fees, California has a managed care organization tax, which is a tax on essentially health insurers around California, and that funding goes right back into patient care and into Medi-Cal patient care. Correct me if I'm wrong, everyone. through those industry taxes, and also the hospital quality assurance fee. Is that what it's called? That's the hospital provider tax, and it's a similar mechanism. And these taxing mechanisms are really essential to bolster the healthcare safety net in California. So just so you guys know. I want to go a little bit deeper into, Ryan, if we could start with you, into the role that universities play. There's a lot of university knowledge and research that's also handled by the university system. And I guess I wanted you to drill down a little bit more on that part of it, and the funding, I'm curious, how dependent are the university health systems on federal funding compared to perhaps private or nonprofit systems?
Yeah, sure. So maybe just to provide a little bit of context initially, UC's academic health centers are part of what we call the designated public hospital system in California. So we're safety net hospitals, and just like the county public hospitals, we are very reliant on state directed payments in particular as a key source. And that's been really the key source of funding that's been growing in recent years. But I think one interesting thing about our financing kind of system or foundation is that we actually don't receive state general fund for the non-federal share. We actually self-finance the non-federal share. So we're very dependent on the federal government when it comes to like Medi-Cal and Medicare, certainly. And so these changes are very concerning.
Supervisor Griffiths, I hear your concern about the sort of collapse, is that too strong of a word, of the system, of the healthcare system. There's a lot of struggles that counties are facing, and you can't really ignore homelessness and the impact that homelessness is having on emergency systems, the incredible strain on county hospitals that are happening. And of course, counties are at the forefront of enrolling patients in Medi-Cal, correct? Is that right?
Yep.
And I think that's sometimes lost on the public. I wanted you to talk a little bit more about, like, there's so many budget constraints right now already, even without HR1. Look at what's happening with the state. California had to cut the expansion of Medi-Cal to undocumented immigrants this year, reluctantly, after a fierce, long fought 10-year campaign to make this expansion. How do counties think about this push and pull of budget constraints and the immense resources that are needed to really make sure people are healthy without creating a tidal wave of healthcare costs down the road?
Yeah, there's a lot in there. I'll try to be succinct about it, but so counties are the level of government that is closest to the people, and so when you think about grand ideas that are produced in Sacramento and Washington, D.C., it's the county's responsibility to implement that on the ground at the end of the day. And counties in California are also responsible for indigent care. We are
Thank you.
the provider of care of last resort. And there's no out for that. There is no, oh, we have exceeded our budget for that for this year. So whatever comes down, we can't fold up shop. We have to figure out how to provide that. And with the I think advances that we've made over the last several years, we're taking people that are homeless or have severe behavioral health issues, or people who have addiction issues, and giving them the wraparound services that prevents that really expensive acute care. And if that all gets taken away, that acute care still has to be provided. And I think this is true for all healthcare systems, but certainly for rural healthcare systems. Wherever the revenue streams come in, you have to figure out how to provide a healthcare system with that amount of money. And so you can have the moral opinion, if you want, or political opinion that undocumented residents don't deserve that, or we should not be paying for that, but yet that care at the end of the day is going to be provided, because hospital emergency rooms don't turn people away. So for a rural hospital and a rural healthcare system, it's a little bit of a zero-sum game there. You're just taking the money off of the top of what's available to provide that service.
One more quick thing. I'm curious, your role as the president of the State Association of Counties and your role as a small county supervisor, are there different struggles in terms of, I'm curious, particularly with lack of access to care and funding between more rural parts of California and perhaps more coastal places? I'm curious if you have thoughts about that.
Yeah. So the state often produces programs that are one size fits all. And I was having a conversation with someone earlier today, like, you can only scale that down so far. Like, you can't hire 5% of a person because that's the amount of funding that comes through for a smaller area. So I think the slide earlier said, we don't compete, we have to cooperate in order to solve it. But we also have to be creative and cobble a lot of things together. We have a project that we're working on in Inyo County now with some bridge housing. And we're basically throwing every population we can into that, of reentry folks, behavioral health folks, people experiencing homelessness, in order to put together a package that pays for itself and makes
State and
sense
federal
at the end of the
funding
day.
then? Package?
State and federal funding. And we're probably going to get to this question later, but as we make these big decisions of a capital investment that we're going to make, with the uncertainties on the Medi-Cal side, should we be making a big capital investment when we don't know that we're going to have the money in order to provide the services moving forward?
Michelle, you have, of course, CBHDA has been really like leading this charge to really improve behavioral health care in California, mental health treatment, mild to moderate and severe, and to improve addiction treatment, substance use treatment in the most clinically appropriate way. Parity has been a major concern despite Senator Wiener's legislation, which was passed, I think, 3 years ago or something, maybe 4, to really look at kind of mental health parity as a cornerstone. I think that's a promise on paper, not necessarily in reality. There's other major issues that were raised, including, I think, about street medicine and the incredible amount of work being done to, for example, deliver antipsychotic injections to people on the street so they can stay out of the emergency room and have that sustainable treatment when they want it. And of course, removing the barriers between counties and health insurers in California for delivery of all types of mental health and addiction treatment. What I'm curious in your mind have been some of where is California doing things right now? And what does the state have to work on in the context of the federal legislation and what's happening nationally?
Thank you for that, Angela. Behavioral health is certainly having a moment. I'm not sure it's quite the moment that we would want. I will say this governor has invested more one-time funding in behavioral health than anyone. It's a once in a generation opportunity, right? Between the investments in the B-CHIP program, which builds, again, buildings for treatment, as well as the home key investments in housing, both of which were extended under Proposition 1, which the voters approved by
So you guys know the B-CHIP is the behavioral health
continuum
improvement
infrastructure program. Yeah.
It basically puts like facilities and counties around the state, right, Michelle?
Well, I mean, these were competitive grants. Counties had to
you.
compete for these grants alongside providers, for-profit and nonprofit, and everybody has to, put a down payment essentially, and then commit to services for at least 30 years. So it's very heavy on the strings, and the state was the decider of which facilities got billed for which services where. And so we are kind of doing this 3D puzzle, right? Where we're trying to figure out, okay, am I going to get this treatment facility to improve flow in the system? And then do I have the ability to finance and recruit the workforce and the services ongoing? Very much like the public hospitals, county behavioral health largely puts up the non-federal share for Medi-Cal services. And that's different from Medi-Cal managed care plans that are paid per member per month. So think about us as like living in a global budget for Medicaid already. And at the same time, under Proposition 1, $1 billion, so a third of our largest funding stream, is being shifted over to housing with a brand new ongoing obligation for county behavioral health to invest that funding in housing. Remember what I said about disabilities and our population struggling with employment for the most part. The turnover rate in that $1 billion worth of housing, not going to be high, right? These are like long-term clients, oftentimes people with severe needs. And so, it's a good thing that we had the one-time investment in behavioral health bridge housing, $1 billion for interim housing, but that population is going to move over into the Behavioral Health Services Act funding stream. And we don't see that there's going to be a whole lot more coming to the table. And the federal budget is also putting at risk housing vouchers. So Section 8, they contribute $8 billion worth of funding into housing subsidies for rent. We're contributing $1 billion starting next year and ongoing. And there's no sort of plan that we can see on the horizon to address the structural drivers of homelessness, which are a lack of affordable housing. And so one of the things that we are very concerned about is when people come into homelessness, often in order to cope and survive, they are either turning to drugs and alcohol for the first time, and or their behavioral health, their depression and anxiety goes up. People cite statistics as high as 66% of the population. Frankly, I don't know how it's not 100% of the population, because if I was on the streets, I know I would be feeling pretty bad. And people often use things like methamphetamines so that they can stay up at night so that they're not attacked or assaulted. And they often use things like opioids or alcohol to sleep. And just basic survival is really the name of the game there. So the more people we as a state and as a society allow to end up on the streets, the greater the behavioral health need will be. We are oncology, we're not causing the cancer, in other words, right? So we really have to reframe and rethink how we view the safety net and where we put our attention. And you mentioned, parity and private insurance. Roughly half of all Californians are covered by some form of private insurance. And I like to say that parity is just the ingenious idea that your behavioral health coverage can be as bad as your physical health coverage. Meaning if you have high copays and deductibles for your physical health services, those same terms apply to your behavioral health coverage. The problem is most people don't go to the primary care office every week or every other week. They may need that for their behavioral health conditions. And so the utter failure at any level of government to address the lack of sort of investment in behavioral health is something that is coming back to bite us pretty hard right now, especially with behavioral health conditions going up. And that does drive increased medical costs and other societal costs. So really would love to see in budget constrained times, the legislature and the governor invest in really bearing down on commercial insurance to make sure that, middle income and even affluent Californians can access insurance paid quality specialty behavioral health services.
I just want to make a mention of, thank you for bringing that up about the HUD cuts, Michelle. Yeah, so the president has issued an executive order which really does kind of look to obliterate the idea of housing first, and with that, the housing choice vouchers. Communities that use these vouchers and implement housing first are facing losing them, and that's many counties in California. So I just want to make a note of that. I want to go to you, Miranda, but before I do, Jeff and Michelle, you guys both talked about this idea of one-time budgeting, and I think that's a really critical issue. Global budgeting, as Michelle referenced, is kind of like an encapsulated, capitated like payment structure. Am I thinking of that right? Okay. This could be its own panel in and of itself, and obviously there's been a lot of efforts through the years to get ongoing funding as opposed to one-time funding for the healthcare safety net for homelessness. But I did want you guys both to touch on that because it can seem a little wonky, but I think it is critical to, as you mentioned, Supervisor, the idea of creating sites for new treatment facilities and new housing, and Michelle for delivery of a range of behavioral health care. So can you guys just talk about really like why is it important to have ongoing funding? People might not understand that.
From a county budgeting standpoint, it is malpractice to tie a future board to a financial obligation when you don't know what that funding stream is going to be. And the lack of certainty, I think, in many ways, we've been in the last 6 months, we've been moving along as if everything's going to be okay because we don't know exactly what the cuts are going to be and where they're going to come from. But at some point, we can't do that anymore. Like, we need some certainty over time when we develop these programs, or it would just be irresponsible.
And I'll just say on the behavioral health, county behavioral health side, the revenue streams that we get in county behavioral health from the state are a portion of sales, vehicle license fee, and millionaires taxes. They don't have anything to do with how many people we're supposed to serve or the intensity of need for those people. Like literally nothing. And so it's here's a pot of money and handle the entitlements that come along with that. And it's actually amazing to me that we managed to do as well as we do with all of the shifts in funding and the one times and the new rules and everything that's happening. Like at the pulling it off part actually amazes me. But I think with respect to our communities and the people that we're serving, it calls into question the viability and the truthfulness of that social contract that we have with people, right? We commissioned RAND, actually, County Behavioral Health, to do an analysis of how underfunded we are just for the adult mental health side of our obligation, not substance use disorders, not kids, not, and they said we have a funding gap between what the state gives us and what we would ideally have in pocket to meet the obligations that we have of $9 billion annually. And so we are significantly underfunded. And the mental health side of our budget, we spend $1 on substance use disorders for every $10 that we spend overall. So $9 is going to mental health, $1 is going to substance use disorders. The needs are immense out there. And again, overall big picture, we have to do more to shore up the 50% of the population that's privately insured. We need to do more to shore up non-specialty mental health, which is the managed care plan's obligation. They get paid a per member per month, no matter what, whether they deliver a service or not. And yes, access to providers and building networks is a problem overall, but I would just suggest that if we don't get the regular insurance plans, meaning commercial plans and managed care plans, really doing their job, we're not going to have the ability to have in a market-based healthcare system an ecosystem of providers that are willing and able to treat everybody's needs. Like we can't keep putting all of this on the safety net end of things. And I'll just say one more thing, which is counties have a really weird contract with the state. It's in behavioral health. Provide the sun, the moon, and the stars to everybody to the extent that resources are available. And so our obligation is slightly different than the 17,000 obligation in that there is that sort of out, but it's only perceived out, right? In reality, if somebody is threatening to kill themselves or harm other people, we're not going to withhold those resources, as Supervisor Griffith said.
Yeah, go for it. And
I was just wondering if I could add one thing to something Michelle said, because I know we have people in the room who are like ledge staff, finance, LAO, people who are going to be really involved in kind of assessing this bill. And I think something that is kind of almost an unfortunate side effect of the way that we analyze things in public policy is that, we're taking a current baseline and then we're trying to estimate the impacts of this policy change. And I think that it can get a little bit lost in that before the policy change, we already had existing, challenges in healthcare, right? Like whether it's affordability, whether it's, boarding and emergency departments, the list goes on and on.
Covered California announced this week or last week that the premiums are going up, and that's even before a lot of the impacts are happening. So to that point, that's a good point.
So kudos to the County Rise folks and the Goldman folks. Really, really excellent work, especially given how recent the bill has passed. But that's really something that I think is important for everybody to keep in mind.
That's awesome. I want to move to questions in a minute. So I just want to kind of quickly go through this. I'm going to give you guys one more bucket, and then please talk about what you want within this bucket. Miranda, I'm curious if you could talk about like the workforce shortages. But before you start, so if you could all address in your respective areas, like two things that have been touched on, which is the expansion of Medi-Cal to undocumented immigrants in California, regardless of the future like premiums that are coming and the freeze on new enrollment that's coming. This is the biggest expansion in the country, and the HR1 does reduce the emergency reimbursement for the adult expansion population of immigrants without legal status from 90% to 50% starting next year. That's for emergency, 65% for pregnancy care. More immigrants are going to be kicked off coverage. I think there's going to be broad ripple effects on that. In addition, we can't ignore CalAIM and the enormous amount of investment that has gone into this expansion. And for all of you guys are probably aware, but the state's advancing and innovating Medi-Cal initiative really looks at housing and social services, food, long-term senior care, intensive case management, all under the rubric of healthcare, as I think it should be, because the evidence bears that out. The way this is done in California, again, the biggest in the country, has biggest expansion like this in the country through a couple of waivers. And the Trump administration has signaled its intent to at least not renew, if not end those, early. So I guess with these major expansions and the funding challenges that you guys have touched on and the workforce shortages, what can California do to really, I'm really curious, to protect, continue, I dare to say, its progress on really improving. This really comes down to making people healthier and helping people, live full lives. Are you worried about that? What gives you pause, and what do you think the state should be working on? Go ahead, Miranda.
Yeah, I'm absolutely worried. More people are going to be uninsured as a result of HR 1. Millions of Californians.
What number of millions do you know? Curious.
We're working on that.
Okay.
But but there are estimates out there for the state that there's so much that's still up in the air about how it's going to be implemented. I mean, the regs aren't even out yet from the feds, and there's a super short timeline for implementing all this stuff. There's just a million questions. But we have evidence from other states that have implemented these red tape work requirements that it's going to catch a lot of people who are eligible are not going to be able to jump through these hoops. And a lot of folks, most folks meet the various exemptions. They're already working or in school or in training or caregiving, right? They're already meeting these exemptions, but they're not going to be able to jump through the hoops needed to keep their coverage, which we've seen in other states that have implemented this. And there's no evidence that it increases employment. So, in fact, it's sort of the other direction, that having stable health insurance helps you get and keep a job. So it's a terrible idea, but it's happening and we have to deal with it, right? And it's going to mean that people lose their coverage and become uninsured, which means that folks are going to live sicker, die younger, and be one emergency away from bankruptcy, right? And that's true not just of folks who are impacted by the work requirements, by needing to go through redetermination of their eligibility twice a year instead of just once a year. It's also true of the immigrants who were targeted by the state cuts, right? So California had this amazing, march towards health equity and universal coverage in 2024, right? When folks were eligible for Medi-Cal, they met the income requirements regardless of their immigration status. And I was so proud as a Californian to be in a state that was doing that. And it's so devastating to have that freeze be part of the state budget, right? Where folks won't have a safety net, right? Like sometimes you churn into needing a safety net, and that's not going to be there. As well as charging premiums for folks who are in these programs, and they're low income, right? $30 a month, that's a lot. That's going to keep people from getting the coverage they need. And while emergency rooms will be open and will treat people, that's not going to get you the oncology. That's not going to get you the cancer care that you need. People are really going to live sicker as a result of not having insurance. Having insurance really matters. And these state and federal budget cuts are going to make more people uninsured.
Thank you. Go to Ryan. Thoughts about the things I brought up.
Yeah, I mean, there was a lot there.
Not to be doom and gloom, but yeah, and just
well, I guess one thing I would say. Okay, so In a prior job, I used to I tried to forecast Medi-Cal caseload for the legislative analyst office. And I was doing this during a time when the state had paused redeterminations and then resumed redeterminations in what was called the unwinding. And cycle after cycle, I was really surprised by how stable the caseload had remained, even though we resumed. I think the general thought was that, you were going to see caseload kind of return back to pre-pandemic
That is
times.
surprising.
And, the best kind of conclusion that I could reach in this work was that measures that the Department of Healthcare Services had put in place in collaboration with county, welfare directors had tried to automate that process as much as possible for enrollees to try and make it as easy as possible. Certainly the federal administration is going to be a pretty big part of the extent to which the state can put those kinds of things in place. But I think there are opportunities to try to limit these impacts. And, one other thing I would say too, that I'm not sure is kind of as widely followed right now as maybe it should be. HR 1 was a huge change, but the federal government is continuing to push regulations. Some want to see a second reconciliation bill. And so there's, more potentially coming down the pike too. And I think that really, yeah, I know it's sorry to be such a doom and gloom, but the point is that, it requires continued focus and advocacy at the federal level.
Michelle, what say you to CalAIM? I'm curious, and I know we could talk for a long time about this. I do want to open up to questions soon, so.
Yeah, I mean, really quickly on the issue of undocumented Californians, as Supervisor Griff said, county behavioral health is at the level of community. And one of the things that we're hearing a lot about are sort of the political determinants of health. So the ways that fear about whether or not someone or their family member is going to be detained by ICE and sent who knows where, or a transgender individual will somehow have their healthcare taken away. That fear factor, the sort of living under the scary sort of news about what might happen to you, to your family, is really impacting and driving up need for our services as well. So I did want to sort of
Political determinants of health. I haven't heard that.
Yeah, I heard it from a colleague and I was like, that's what we're talking about. Exactly. And so there's that sort of element. In terms of CalAIM, I want to commend the state. They're currently looking at the waiver renewals for our 1115 waiver, which includes drug Medi-Cal organized delivery system, or ODS. That is the mechanism that we use to pay for residential inpatient substance use disorder treatment. Fun fact, since the inception of Medicaid, Medicaid has not ever paid for inpatient and residential mental health or substance use disorder treatment services. It's a kind of a carve out in facilities over 16 beds. And so for a state the size of California, outside of Inyo County, it can be really tough to deliver those highest cost services. And at a time when we have Prop 36, which is the the felony mandated treatment, and other initiatives that are sort of driving people to the deep end of the pool, so to speak, for behavioral health conditions, we really need Medicaid. I mean, I think that's the point here, right? Like at the end of the day, Medicaid is one of the pillars that makes this work in California for so many low-income people. And if we pull those pieces away, it just sort of puts us in this death spiral, quite literally, of more need, more suffering, and to what end, right? Like the reality is all of us will be impacted, and it's not just through jobs. It's not just through, the people who directly lose their insurance, but like, I'm worried about my own child getting exposed to infectious diseases that otherwise could have been prevented. Thank you very much. Right? Like we really, what we're losing ground on is the sort of social contract that we currently have of feeling like we can live in a healthy community where our neighbor is getting what they need at the end of the day.
Okay, so that was a lot. Again, I'm gonna try to distill it. And you, so the hard question you put is, what should the state be doing? Because I'm like, well, they're gonna have to make some really hard decisions. There's not infinite money that they're going to be able to get to backfill things. But I wrote it down, but eligibility is, I think, something, investing in county eligibility workers is something that they can do. I think that will have a lot of benefit in that with the twice a year determination, the complicated paperwork that people are going to have to fill out, the fear factor that you talked about. There will be people that will be eligible but think they're not going to be eligible, or they will be eligible but they're fearful of seeking that eligibility, and that's where county eligibility workers can step in.
So making sure people don't fall off.
Making sure people don't fall off. Yeah, doing that outreach. That's the end of the positive suggestions I got. I think everything else is kind of, so my biggest worries, like two of them are the systemic stuff that we've talked about before. And I just want to point out two areas that are particularly I'm worried about in rural hospitals, and that's skilled nursing facilities and birthing centers. I live in Bishop, California. We have the only birthing center within a 3-hour radius.
Wow, really?
And a huge percentage of that is Medi-Cal. A fairly large percentage of that is Hispanic, of various immigration statuses, but certainly that's going to have, and also birthing centers are not profitable for hospitals to begin with. And so that's sort of an existential worry for a community if you have to drive 3 or 4 hours to have a baby. The other thing that I really worry about downstream from all of this is when people lose their health care, they're exposed to more medical debt. They're exposed to more acute outcomes. And those things lead to loss of employment. Those things lead to loss of housing. Those things lead to behavioral health issues, substance use issues. They're going to have impacts on our jail, our foster care caseloads, on and on and on and on and on. Basically, a whole half, 3/4 of what counties do with humans are going to be negatively impacted by this. And that all of that adds up to a lot more than whatever the X amount of money counties are losing from HR1.
Thank you for making those connections. Questions are open. Yeah.
So as our expert panel knows, this is not the first rodeo for work requirements. There's a long history of relying on work requirements to try to reduce roles. And I'm wondering, from your perspective, what we have to learn from those past episodes, from SNAP, from welfare reform, about better and worse ways to create and sustain the eligibility system, because that's the linchpin for reducing the roles. So if that linchpin didn't turn out the way the federal government plans, that would be helpful. I'm just wondering what we know about the past that would help us understand better and worse ways to come at this.
I will say one thing that we learned talking to eligibility workers in 2015 as the ACA was rolling out was just how important involving them in continuous training, continuous learning, sharing with each other, really involving those eligibility workers in the process. And I think especially given the short timeline for implementing these work requirements that counties have, that the state and counties will have, it's gonna be a bit of a mess. And so it'll need to be part of this continual improvement process and involving the workers in that. Because, they're sitting down with folks. They see the challenges of, the messiness of people's lives that need to fit in these little boxes, and they'll be able to raise that. So that's one thing I'd highlight.
The other thing I just want to mention is the double-edged sword of the era of data and technology, right? Like we kind of can draw some lessons from the past, but also we're in a very different moment politically, but also in terms of the tools that we have. And I'm not going to say good or bad. I don't think it's binary. I think it is, right? And we've heard not just at the state level, but also at the federal level, lots of discussion about, can they use AI to do data matching, for example, and pull from different data systems to automate it. So the assumption there is we'll make it all very easy, right? Then we don't need humans. We can just put it in the machine and the machine will tell us who's eligible. And my issue with that, my challenge is we don't do a great job of collecting data around disability, period, right? And so for all of those people who theoretically would qualify for exemptions on the basis of disability, that's a big whoa dog for me, right? But that there are industries that are pitching, very expensive products to government as the purchaser to do this data matching work, and lickety split, it's all going to happen on a very fast timeline, right? So that's something that I would really keep an eye on. That coupled with the data breach, the alleged or literal, I don't remember. I think it did happen. Leak of data from Medi-Cal into Department of Homeland Security with people's personal information adds to the fear factor, adds to that, again, the trust that we have with the public about what are we doing with all the information that we're collecting from them. And so there's this real tension right now between federal and state pulling in two different directions. And yes, data, but data might also come with significant risks. And I think that the sort of tension of the pull in both directions really marks the sort of moment that we're in right now in healthcare. Like, we can see the upsides, but is it worth the risk is the question.
Are there more questions?
Not a question. I just wanted to add on the data point, since we saw the firing at the federal level of the person responsible for putting out data. If the administration doesn't like it, the data, we're in a danger that they're going to change it so it's federal favorable to them and dispute any county challenges that numbers are wrong or unfair. Just our numbers are wrong and theirs will be right.
And that's a really good point. And Michelle, I think just to address that point you raised, yeah, I think there's been a reporting, including by the Associated Press, that the federal government did share CMS data with the Department of Homeland Security, and I think it's ongoing. Although the state's Attorney General Rob Bonta is leading the lawsuit with a bunch of other states to challenge that, but there has been some solid reporting on that's happening, and you can just look to places like Los Angeles where you can see the impacts of that. Any other questions? Yeah.
Hi, thank you, everybody. This is amazing. I guess I have maybe a comment that no one probably wants to answer right now, but does it drive anyone else nuts that we keep talking about ourselves as the fourth largest economy, yet we have a third of our population on Medi-Cal, 50% of them are kids, we can't figure out good ways to do some of the basic functions. And I'm just curious, when we get to that harder conversation, the collective we, right, around how do we resource our adult behavioral health system? I mean, all the points we mentioned in the state that purports to be the fourth largest economy. Like, when is this the time where we have to really push on that, despite the discomfort with taxation and fees and all the other things people don't want to talk about? Is this the time that we need to shift how we talk about how we resource our collective well-being?
I think about that. I think about that a lot as a reporter too. Income inequality and the extreme poverty, and actually the Public Policy Institute of California, I think they just recently came out with a new report on this. But I think that's a really big deal if you look at homelessness and housing. Do you guys have thoughts about that? And this will be the final point. Is that right, you guys? 1:30? Yes. Okay, great.
So this isn't really necessarily a response to your comment, but I would just point out that, the fourth largest economy stuff is really mostly about like political subdivision boundaries than it is about, but I mean, it has to do with like our borders and how we draw, and the point I was going to make is that you may remember years ago, somebody had proposed an initiative that was called 7 Californias. And 7 Californias would have created both the richest and the poorest state in the country. So I think that gives you a sense of kind of the variation. Tim Draper, I believe. Yeah.
I mean, I guess so as a county supervisor, that's all about my pay grade. But I would make the argument that the United States of America is the wealthiest nation in the world. And so it's not a California problem. It's all over the country. And as county officials, or as, people who are involved in the service delivery, we, it doesn't that doesn't matter in the sense of, like, we get a set of resources and a set of rules, and we have to figure out how to do the best we can with that.
But I will venture to say, I mean, I do think that the question is a valid one, in the sense that we've spent a lot of time talking about personal responsibility for individual decisions. And at what point do we acknowledge the sort of structural factors that drive so much of this, right? And I do think that there's something empowering about what is within your control. What can you change, right? It does take a ton of political will, and we do live in an era of, information, disinformation, and et cetera. So that's a pretty serious headwind. But I do think that sort of resetting the table on how we think about some of these things, how we talk about them, is in the hands of the academics and the, folks who do research, such as it is today. And yeah, like looking at rethinking, how we're financing, how we're structuring, what kinds of rules apply to whom, et cetera. Like, there's still a lot that could be done, and we ought to be thinking about that. We ought to be working on those solutions.
And just for the wonks out there, there's some great CBO diagrams of HR1, right? And the distribution of the winners and losers. And the losers, the folks who are going to be losing SNAP and losing Medicaid, are down here, and it's a significant loss. There are winners, right? There are winners who are going to be paying fewer taxes. And so, to your point, yes, it drives me crazy because it's an obvious, anyone who's ever done a personal budget understands, right? Like, you can restrain what you're paying out, or you can take more in. That's a legitimate option. And so I think it should be part of the conversation.
Thank you guys. That was very informative. Thank you all. I always learn so much from you guys. Thank you. Thank you.
So just to close us out, before we panelists, if I may, I just have one announcement for our group. Just want to say thank you again, everyone, for staying with us, being attentive to this conversation. And we're going to go, so this part of the programming is ending, and we're going to have a 15-minute break. And then we have another panel, speaking of the conversation that we need to have about reimagining government. We are going to have a panel that is just from the UC Berkeley Goldman Policy School on Agile Government Initiative. We have some panelists that are going to be teaching in this semester's courses. And so if you'd like to join, please feel free. We'll probably just stay in this area. And so we'll start at 1:45. And then panelists, if you'd be open to a group picture out in the lobby. And thank you again, everyone, for showing up today.